Good morning, good afternoon, and good evening once again. Here we are in an important section of this conference. Till now, you have been listening to the invited speakers. And as you know, there was a scope of submitting abstracts in the conference website. A good number of abstracts were submitted. Among these, 4 were judged to be the best by the scientific committee, and these are selected for oral presentation. The first paper is going to be presented by Song Jue from University of Bern, Switzerland, and the title of the paper is Voxel-wise Prediction of Post-Therapy Dosimetry for 177 Lutetium PSMA INT Therapy. The co-authors of this paper are Andrei Gafita and Kuangyu from the Technical University of Munich, Germany. May I invite Song Jue for his presentation.
Good afternoon. Hi, everyone. My name is Song. I'm from University of Bern and Inselspital. Really appreciate this opportunity to present one of my recent work here, which is about the Voxel-wise prediction of post-therapy dosimetry for lutetium-177 PSMA radioligand therapy. As we all know, prostate cancer is the most common cancer among men, and radioligand therapy is a rather effective treatment. For example, this work by Afshar in 2016. As you can see, the tumor lesions reduced to a certain level after several cycles of the lutetium-177 PSMA therapy. However, concerns have been raised, such as suboptimal results on a fraction of patients, and also the dose effects and complications, which requires further optimization. Since these years, artificial intelligence have grown really fast, so we have the reason to believe that it can also help us in the dosimetry prediction. Here we propose a novel framework based on the state-of-art generative adversary neural network to estimate the Voxel-wise dosimetry distribution. During the process for training, the generator here is to synthesize fake dosimetry image based on the input of pre-therapy PET image, and the discriminator here aims to distinguish between the estimated dosimetry image and the real dosimetry image. So it's more like a competing game between these two. And the ultimate goal is to come up with the best network of the generator, which would eventually be able to generate a real dosimetry image based on any pre-therapy PET image as possible. And it's worth mentioning that, as shown before, the model is trained here on the dataset of PSMA INT. And then the model is evaluated on both the INT for cross-validation and also for PSMA 617 for external evaluation. And here is our example of the PSINT. We plotted the coronal maximum intensity projection to better visualize the result. And these 2 columns represent 2 examples from our test dataset. And as you can see, we input the test data, which is the pre-therapy PET on the first row to the trained model. And then we got the prediction of the dosimetry image on the third row, which reached the 3.3% and the 3.8% for the normalized root mean squared error. And the last row represents our PET and CT-based model, which incorporates information from both for the purpose of anatomic registration, and it achieves similar precision. And here we show the result of a PSMA 617, and we were able to achieve similar accuracy compared to the previous INT dataset. And furthermore, we did a 6-fold cross-validation to further evaluate the robustness of our model, where we randomly selected 20% of the data for testing as 6 folds, and the model appears to be consistent along each fold. And for another, surprisingly but encouragingly, the result of a PSMA 16, which is the external dataset, achieved lower error compared to the PSMA INT. And we also evaluate the result in some other ways, for example, for the dose volume histogram for each organ. And due to the limit of time, we cannot show you here. So to draw a conclusion, our experiment results demonstrate the potential of artificial intelligence to estimate the Voxel-wise proposed therapy dosimetry, and it may provide a solution to improve the dosimetry guide treatment planning for radioligand therapy. And also I want to mention some limitations to our study. So first is the limit of amount of data, which we know it's pretty essential to the deep learning or the artificial intelligence. And also we here use the semi-supervised model, which requires the pre-generated dose map as ground truth. And due to the current techniques for that, we still it may affect the precision of our ground truth. And yeah, basically that's it. Thanks for your attention.
The second presentation in the session is going to be presented by Knut Liepe from GH Hospital, Frankfurt Oder, Germany. Now, Knut Liepe is a very well-known member in Wang, and he was a couple of times in the executive board, and we are eagerly waiting for his presentation. The title of his presentation is Technetium 99M PSMA SPECT-CT is a valuable alternative to gallium-68 PSMA PET-CT in prostate cancer patients. The co-author of this paper are Marcel Baehr and Bernd Kuhn from the same institute. So may I invite Knut Liepe for his presentation, please?
Okay, thanks for the kind introduction. I will show you our experiences, but I don't see my slides yet. Can you bit little? Thanks for the kindly introduction. I will show you our experiences with the PSMA SPECT-CT. The gallium PSMA PET is a diagnostic of modality of first choice in patients with concerning metastasis outside the skeletal system. But unfortunately, PET-CT systems are not available worldwide. The gallium PSMA is expensive, and the costs are not covered by the health insurance in all countries. For example, in Germany's health insurance don't pay for the gallium PSMA PET-CT. And so the PSMA SPECT-CT could be helpful in patients with PSA relapse and with primary staging if a gallium PET-CT is not available. So next slide, please. Okay, to the methods. SPECT-CT were performed in 115 patients. 78 patients had a biochemical recurrence of prostate cancer, and 32 patients were investigated in primary staging of prostate cancer, especially before local radiotherapy. And in 5 patients, we used SPECT-CT in association with lutetium PSMA therapy. 36 patients received a bone scan and a PSMA scan within 1 month. And so we can compare this both diagnostic modality, and we have a wide range of PSA level and also for the PSA doubling time. So next slide, please. To our results, 100% of the primary tumor was detectable in non-technetium PSMA SPECT-CT, and we found additional positive lymph node metastasis in 16 patients compared to MRI or CT and the bone scan. And so this patient was upstaged. In biochemical recurrence patient, we have 52% of positive findings, and we look for the patient with a lower risk of prostate cancer. There, 44% of the patient was positive, and in the group with a high risk, that is up to the Gleason score of 8, 65% of the patient was positive. The lowest PSA level in a patient with a positive PSMA SPECT-CT was 0.14, that is very low. And in patient with negative results, the lowest PSA doubling time was 5.9 months. And if we compare the technetium PSMA and the technetium MTP SPECT, then in 92% of the patients, we have a concordant finding, but 3 was discordant. In one patient, the bone scan was false positive after a local radiotherapy, we know that. But in 2 patients with multiple bone metastasis, the PSMA spectroscopy underestimate the bone metastasis. So next slide. Here, one example of a very small lymph node metastasis. Here the size was 8 and 4 millimeter, and also a very small bone metastasis, 8 and 9 millimeter, and this bone metastasis was not finding in the additional CT. So next slide. But we have also a possibility of false positive findings. Here, one example in an inflammatory process in the iliopsoas muscle and the symphysis. We performed a second SPECT-CT 24 hours, and here we found similar findings as in the SPECT-CT 4 hours after injection. The next slide, please. And here, one example of a false positive finding in the bone scan. This was a patient with, after the radiotherapy in the spine, and we look for the other positive findings in the pelvic. Here, the patient was positive in bone scan and also in the technetium PSMA scan. So next slide, please. Let me conclude. PSMA SPECT-CT is a useful alternative to PSMA PET-CT. It is not available. We can use it in primary staging, in patients with high-risk patients, or before radiotherapy for a better planning of the radiotherapy. We can use it in the biochemical recurrence if the PSMA doubling time is lower than 6 months. And we found also positive lymph nodes in patients with a low PSA level. And we can use it for the indication and the follow-up of lutetium PSMA therapy. And for the future, it would be interesting if the technetium PSMA SPECT-CT can substitute CT plus MTP SPECT-CT in patients with primary staging of high-risk prostate cancer. Thanks for your interest.
The third paper in the session is going to be presented by Feng Wang from the Peking University Cancer Hospital, China. And the title is The Possibility for the Dosimetry of Lutetium-177 PSMA Therapy in Prostate Patients Using Less Imaging Acquisition Time Points. And the co-author of this presentation is Ji Yang from the same institute.
Dear Chairman, ladies and gentlemen, it is really my great honor to present my presentation. I would share my paper, The Possibility for the Dosimetry of Lutetium PSMA Therapy in Prostate Patients Using Less Imaging Acquisition Time Points. I'm Feng Wang from Peking University. Conclusion. First, I will introduce the background. Okay, next slide. First, I will introduce the background. As we all know, the dosimetry is very important for the treatment of lutetium PSMA patients to maximize the therapy effect of tumors while minimizing the radiation burden to other organs as soon as possible. So, however, in order to get the residence time of the organs, several scan time points would be required to determine the integrated activity that puts a burden on patients and the clinical results. Therefore, whether is it possible to determine the dosimetry of lutetium PSMA therapy in prostrate patients using 1 point or 2 time points measurement? Therefore, this paper tries some methods using 1 time point or 2 time points to determine the dosimetry. Next slide. For the normal dosimetry for the patients, the absorbed dose of kidneys and the tumors of the lutetium PSMA therapy for prostrate patients were calculated using the 5 time points 0.5 point, 3, 20, 44, and 6 8 hours post-injection. The dose estimation consists of the IOI drawing fitting the time activity curve, getting the residence time and the dose estimation from the Olinda software. The dose estimation from the 5 time points is considered as the golden standard value for comparison. Totally, 43 cycles from the first treatment cycles of patients who had received several cycles of lutetium PSMA therapy were chosen for study. Okay, now I will introduce the 4 different protocols for the dosimetry of kids and the tumors of the lutetium PSMA therapy for the prostate cancer patients using the 1 time or 2 times point method. Okay, next. This is the 4 different protocols as followed. We can see from the screen. Protocol 1, based on some experience, the resistance time tau could be calculated from the just 1 time point activity measurement from the formula as follows. The protocol 2 will assume the average active half-life of the lutetium PSMA in kidney and tumors are the known parameters, so we can calculate the residence time of the kidneys and tumors from the effective half-life. Protocol 3, we use 2 different time points as follow: 220 and 344, 368, 2048, 2068, and the 2468. 2 points to fit the residence time and get the formula. And the protocol 4 will use 6 different groups of the 2 times points, as we can see from the screen. So for different protocols, we get different results. The next slide. We can get the results. Protocol 1. It got about less deviations, 10% from the golden standard data using the 8 hours data in kidney dosimetry estimation, while got the 10% deviation in tumor dosimetry estimated using 28 hours data. Next, protocol 2, it also got less deviation, 7.5% from the golden standard data using 6 to 8 hours data in kidney dosimetry estimation, while got the 11% deviation in tumor dosimetry using the 68 hours data. Next, the 20 and the 68 group got the less variation in kidney and tumor absorbed dose estimation compared with the golden standard data. As for the protocol 4, the next slide, we can see the 0.5, 44, and the 68 group data got the less variation from the golden standard data in kidney absorbed dose estimated. However, it got a huge deviation from the golden standard data for the tumor estimation. Okay, next. Finally, I would like to take a conclusion with the presentation. First, it is accuracy with deviation from 7.7% to 11% compared with the golden standard data using 4 different protocols to allow the routine personalized dosimetry when it is in practice practical to make a multi-point data acquisition. Protocol 4 got the latest variation in kidney associated dose estimated. Protocol 3, the 20th and 6th add group got the latest variation in tumor associated dose estimated. So it is possible to determine the associated dose of kidney and tumor in the treatment of lutetium PSMA patients using less time points acquisition. Okay, that's all. Thank you very much.
And here we come to the final presentation in this session. After this presentation, the session will close. And it is from Cati, Raluca, Stolniceanu from Romania. And the title of the paper is New Quantitative Nuclear Functional Imaging Data in NET's Theranostic Approach. From Cati, Raluca, Stolniceanu from Grigore T. Popa, University of Medicine and Pharmacy, Romania. So, Dr. Cati, please, the floor is yours.
Hello, everyone. My name is Cati Raluca Stolniceanu. I am from Iași, Romania. First of all, I must say that it is a great honor for me to present a part of my PhD research results during this extraordinary congress organized under warrant auspices, and I want to thank the organizer for offering me this opportunity. My presentation is structured in 5 parts, with emphasis on used method on achieved results. Somatostatin receptor imaging represents gold standard in NET's patient management, shaping the PRRT patient profiles. Our objective was to establish and statistically evaluate the new quantitative parameters for scintigraphic evaluation within the theragnostic approach of patients with neuroendocrine tumor. We investigated over a 12-month period 43 patients with histologically proven neuroendocrine tumors from 2 medical centers, Department of Nuclear Medicine from St. Spiridon Hospital from Iași, Romania, and Department of Nuclear Medicine from Clinical Center of Kragujevac from Serbia. Using 99M technetium tetrotype and applying the image acquisition protocol, we obtain 43 clear whole-body scintigraphy images. On each one, we identified identical region of interest for each area of pathological uptake and physiological uptake areas considered to be of study interest, like liver, lung, and spleen. The uptake was quantified, correcting the activity related to the background upper right type. So, for each primary or metastasis neuroendocrine tumor with liver localization or non-liver localization, we obtain pure tumoral uptake and corrected the region of interest for liver, for lung, and for spleen. With this corrected value, we defined 3 uptake indices. I2, I1, its ratio between pure tumoral uptake and corrected region of interest for liver. I2 is ratio between pure tumoral uptake and corrected region of interest for spleen, and I3 is pure tumoral uptake and corrected region of interest for lung. Regarding our results, for all our 43 patients, there were differences between corrected and uncorrected indices values, differences highlighted by kinetic uptake graphs. Regarding our statistical analysis, we made a Spearman correlation in order to assess the relationship between the corrected and uncorrected physiological, pathological quantitative uptake indices. And the Spearman coefficient was 0.88 for first group, 0.87 for second group, and 0.9 for third group, showing a strong positive correlation between corrected and uncorrected quantitative uptake indices. In conclusion, corrected uptake kinetics indices next to the tumor heterogeneity graphs can describe more precise the radiotracer biodistribution, representing an important nuclear functional imaging feature in NET's neuroendocrine tumor theragnostic approach. Thank you for your attention.